Hello and welcome to my channel. This is Pritesh Jadhav and today we shall be dealing with an important clinical symptom known as dyspnea. So without further ado, let's get started. Firstly, with the definition of dyspnea. A subjective experience of an uncomfortable breathing is the first symptom and it is often increased with work of inhalation and exhalation. Assessment begins by determining the quality and intensity of this discomfort. A dyspnea typically results from a cardiopulmonary problem that causes an increased drive towards the breathing, an increased work of breathing with or without the stimulation of specific receptors in the heart, lungs or the vasculature. For the purpose of this video, we shall be dealing with the causes of respiratory system and the cardiovascular system separately. Firstly, we shall see the causes of dyspnea of the respiratory system. Airway disease. Asthma and COPD are the most common causes of dyspnea associated with an increased work of breathing. Bronchospasm can cause chest tightness and hyperventilation. Hypoxemia and hypercapnia can result from ventilation-perfusion mismatch. Chest wall stiffness, which is seen in kyphoscoliosis, and neuromuscular weakness like in myasthenia gravis can cause an increased work of breathing. Lung parenchymal diseases like the interstitial lung disease cause a reduction in the lung compliance and an increased work of breathing. Ventilation perfusion mismatch and pulmonary fibrosis may also lead to hypoxemia. Stimulation of the lung receptors can cause hyperventilation. Now we shall move on to the causes of cardiovascular dyspnea. Firstly, the left heart disorders. Elevation of the left ventricular end diastolic and the pulmonary capillary wedge pressures can lead to dyspnea, which is related to the stimulation of the pulmonary receptors and hypoxemia from a ventilation perfusion mismatch. Secondly, the pulmonary vascular disorders. Pulmonary emboli, primary in pulmonary artery hypertension and pulmonary vasculitis, but the receptors can cause dyspnea. Hyperventilation and hypoxemia may contribute to the dyspnea. Pericardial diseases. Constrictive pericarditis and pericardial tamponade can cause an increase in the intracardiac and the pulmonary arterial pressures, leading to dyspnea. Dyspnea with a normal respiratory and cardiovascular system can cause dyspnea like in anemia. Obesity is also associated with dyspnea due to a high cardiac output and an impaired ventilatory function. Decongestioning may also contribute as well. Now let's look at how to approach a patient with dyspnea. On history, firstly obtain the description of this discomfort, including the impact of the positions, infections and various environmental exposures of the patient. Orthopnea is commonly observed in congestive heart failure. Nocturnal dyspnea is seen in CHF and asthma. Intermittent dyspnea, which suggests a myocardial ischemia, asthma or pulmonary embolism. On physical examination, assess the increased work of breathing, which is indicated by the accessory ventilatory muscle usage. Determine if the chest movement is symmetric. Use percussion, which is dullness or hyperresonance, and auscultation, causing a decreased or adventitious breath sounds to assess the lungs. Cardiac exam should also note the jugular venous distension, Hyatt murmurs, S3-S4 gallops. Clubbing can also relate to the interstitial lung disease or lung cancer. To evaluate exertional dyspnea, reproduce the dyspnea with observations while assessing the pulse oximetry. On radiographic studies, chest radiograph should be obtained as an initial evaluation. Chest CT scan can also be subsequently used to assess the lung parenchyma, example in emphysema or interstitial lung diseases, and also in pulmonary embolism. Laboratory studies. ECG should be obtained. Echocardiography can assess the left ventricular dysfunction, pulmonary hypertension and valvular diseases of the heart. Pulmonary function test to consider include spirometry, lung volumes, diffusing capacity of the heart of the lungs. Methacholine challenge testing can assess for asthma in the subjects with normal spirometry. cardiopulmonary exercise can determine whether the pulmonary or cardiac disease limits the exercise capability. A brief about the treatment for dyspnea. Ideally, treatment involves correcting the underlying problem that has caused the dyspnea. Supplemental oxygen is often required for significant oxygen desaturation at rest or with exertion. Pulmonary rehabilitation is also useful. If you found this video informative, please consider subscribing to this channel for further such videos. Thank you.